Hello, ladies and gentlemen. I am Dr. Hong Hao Zhang, Chief of the Division of Endocrinology and Metabolism. It's my great honor to have this opportunity to talk to you about initiating SGLT2 inhibitor and or GLP-1 receptor agonist in inpatient setting. First of all, let's take a look at the cardiovascular and renal protective effect of GLP-1 receptor agonist. This meta-analysis is from the Lancet Diabetes and Endocrinology, published this year. It enrolled 8 currently available cardio safety trials of GLP-1 receptor agonists, including ELIXA, LEADER, SUSTAIN 6, Excel, Harmony Outcomes, Rewind, Pioneer 6, and Amplitude O. Structurally, the GLP-1 receptor agonist can be divided into 2 categories. One is exenatine-based, which include lisizanatide, exenatide, and FP-grenatide. The other one is human GLP-1 analog, which include liraglutide, semaglutide, albiglutide, and dulaglutide. From the result of this meta-analysis, we can see that the use of GLP-1 receptor agonist can reduce the risk of 3-point MACE by 14%, reduce the composite kidney outcome, including macroalbuminuria, by 21%, reduce the total mortality by 12%, and interestingly, can reduce the hospitalization for heart failure by 11%. This analysis of his subgroup for 3-point MACE found that regardless of whether the patient had cardiovascular disease or not, does not affect the benefit of the GLP-1 receptor agonist. It suggests that GLP-1 receptor agonists are cardioprotective for both primary and secondary prevention. In addition, whether you use daily or weekly GLP-1 receptor agonist does not affect this cardiovascular benefit. Whether exenatine-based or human GLP-1 analog also does not affect the cardioprotective effect of GLP-1 receptor agonist. So the conclusion of this meta-analysis tells us that the use of GLP-1 receptor agonist in patients with type 2 diabetes can effectively reduce the risk of individual MACE component, all-cause mortality, hospital admission for heart failure, and worsening kidney function, regardless of structural homology. The other medication is the SGLT2 inhibitors. Also, let's look at the meta-analysis of cardiorenal effect of SGLT2 inhibitors. This study was published in JAMA Cardiology this year. It enrolled 5 currently available cardiovascular safety trials of SGLT2 inhibitors in patients with type 2 diabetes, including EMPA-REG, CONVERSE program, DECLARE, CREDENCE, and VERTIS CV trials. The result of this study show that the use of SGLT2 inhibitors can reduce the risk of overall mass by 10%, reduce the overall hospitalization for heart failure by 32%, and reduce the overall kidney outcome by 38%. Clearly, from these two meta-analyses, both the SGLT2 inhibitors and GLP-1 receptor agonists have cardio-renal protection effect in patients with type 2 diabetes. This table is the drug-specific and patient factor to consider when selecting anti-hyperglycemic agents from the 8 American Diabetes Association recommendations. So we can see that the SGLT2 inhibitor have intermediate glucose-lowering efficacies and will not cause hypoglycemia and will promote weight loss. And it had cardiovascular effect or benefit for both ASCVD and heart failure. For the renal effect, the SGLT2 inhibitors also benefit in the progression of DKD, but need some renal dose adjustment. The additional conditions of SGLT2 inhibitors is that it should be discontinued before any scheduled surgery to avoid potential risk of DKA, and should consider DKA risk for all agents, and the risk of bone fractures, and genital urinary tract infections, and risk of violent depression, hypotension, and risk of foreigners gangrene. That's SGLT2 inhibitors. With regard to GLP-1 receptor agonist, the glucose lowering efficacy is high, and it will not cause hypoglycemia, and it promotes weight loss better than the SGLT2 inhibitors. And it both should be, here the ADA recommendation here is that the SCVD effect is neutral for some GLP-1 receptor agonists and neutral for heart failure hospitalization. However, the meta-analysis that we just show you is the GLP-1 receptor agonist have cardioprotective effect for both ASCVD and hospitalization for heart failure. So it might change in the upcoming recommendations. As for renal effect, the GLP-1 receptor agonists have benefit for the progression of DKD, and some need to adjust dose for renal function. The additional considerations of GLP-1 receptor agonists is that the risk of thyroid C-cell tumor in rodents, but the human relevance not determined. And the GI side effects is common, including nausea, vomiting, and diarrhea, and injection site reaction. The pancreatitis has been reported in clinical trials, but causality has not been established. But it should be continued if pancreatitis is suspected. So that's the ADA recommendation for SGLT2 inhibitors and GLP-1 receptor agonists used as outpatient. So what's the diabetes care in the hospital? Let's look at the standard of medical care in diabetes, also from the American Diabetes Association. So with the GLP-1 receptor agonist, the recommendations for the inpatient say that several recent randomized trials have demonstrated the potential effective of GLP-1 receptor agonist and DPP-4 inhibitors in specific group of hospitalized patients. However, an FDA bulletin states that providers should consider discontinuing saxagliptin and elogliptin in people who develop heart failure. For SGLT2 inhibitors should be avoided in case of severe illness, in patients with ketonemia or ketonuria, and during prolonged fasting and surgical procedures. Until safety and effectiveness are established, SGLT2 inhibitors are not recommended for routine in-hospital use. Furthermore, the FDA has recently warned that SGLT2 inhibitors should be stopped 3 days before scheduled surgery, 4 days in the case of ertugliflozin. So that I think that should be, we had little evidence for these two kinds of medication for inpatient use. And this retrospective study is to determine the incidence, character, and outcome of DKA that develop in the community or during the course of admission in SGLT2 inhibitor users with type 2 diabetes. The incidence of DKA for SGLT2 user is 1.02 per 1,000, sorry. And for non-SGLT inhibitors, the incidence of DKA is 0.69. So the hazard ratio is 1.48. That reached statistical significance. The SGLT2 in users were more likely to develop DKA as an inpatient. The old SGLT2 inhibitors users had continued to take the SGLT2 inhibitor up to the day of hospital admission, and 38% continue to take SGLT2 inhibitors during the inpatient admission. So why we think that it's time to consider initiating GLP-1 receptor agonists and or SGLT2 inhibitors in inpatient setting? Because GLP-1 receptor agonists can reduce mass mortality, hospitalization for heart failure, and worsening kidney function. And it also facilitates significant weight loss. SGLT2 inhibitors can also reduce mass hospitalization for heart failure and kidney outcomes. In addition, as an inpatient, the safety of these two medications can be monitored. However, most participants enrolled in the cardiovascular outcome trials were outpatients. So when starting SGLT2 inhibitor or GLP-1 receptor agonist in inpatient aim to improve CV and renal outcome would be an extrapolation from existing trial data. Because short-term risk and benefit may be different in the hospitalized patient, not for CV or renal outcome protection. This review article to address the use of GLP-1 receptor agonist in hospitalized patients. Pilot studies were reported in the fields of acute stroke, cardio resuscitation, coronary care, and perioperative care that showed advantage of GLP-1 receptor agonist therapy with normalization of glucose, lowering glucose variability, and lower risk of hypoglycemia, but not for cardiovascular protection and renal protection. The increasing use of GLP-1 receptor agonists in outpatient means that patients using this medication will become increasingly seen in acute settings. So trials are needed to establish their place in acute illness. For example, this is an example of GLP-1 receptor use in inpatient. It's a randomized control trial on safety and efficacy of exenatide therapy for the inpatient management of general medicine and surgery patients with type 2 diabetes. The study was divided into 3 groups, and one group used a basal bolus regimen, the black colored, and the other used exenatide plus basal insulin, is the white box, and exenatide alone. So we can see the panel A that the mean daily blood glucose was similar between patients treated with exenatide plus basal insulin and basal bolus regimen. The panel B showed that exenatide plus basal insulin resulted in a higher proportion of blood glucose level in target range compared with exenatide and the basal bolus regimen. The panel C showed the day-to-day mean blood glucose. So we can see that the exenatide plus basal insulin is similar with the basal bolus. However, more patients in the exenatide and exenatide plus basal insulin group experience nausea or vomiting than in the basal bolus group. So it showed the glucose lowering effect and the side effect monitoring in the inpatient. This review showed that the use of SGLT2 inhibitors in the inpatient setting. The rationale behind the use of these agents in the inpatient setting is based on the low risk of hypoglycemia, the practical dosing scheme, and the potential to decrease subsequent heart failure admission rate. SGLT2 inhibitors have been linked to specific adverse events related to their mechanism of action, including an increasing risk of euglycemic DKA and violent depression, which raise concern over their usefulness in inpatient. However, the potential benefits derived from the use of SGLT2 inhibitor in the inpatient setting cannot mitigate possible risks, at least until robust evidence on their efficacy in hospitalized individuals become available. So also we can provide 2 examples of SGLT2 inhibitors for inpatient use. This is the DARE 19 trial. I believe you saw this before. It's published also this year in Lancet Diabetes Endocrinology. The dapagliflozin in patients with cardiometabolic risk factors hospitalized with COVID-19. It's a randomized double-blind placebo-controlled trial. The design includes adult patient hospitalized with confirmed or strongly suspect COVID-19, and a 30-day treatment period with placebo or dapagliflozin 10 mg per day. And the key inclusion criteria including hospitalization with confirmed or suspected SARS-CoV infection, O2 saturation of more than 94% on less than 5 liters per minute. The chest X-ray findings compatible with COVID-19 infections, and more than one risk factors, including hypertension, type 2 diabetes, SCVD, heart failure, and CKD. The key exclusion criteria including critical illness on presentation, eGFR less than 25, type 1 diabetes, or prior DKA. So the study enrolled relatively stable non-critical illness patients. And finally, half patients have type 2 diabetes and half does not have type 2 diabetes. So the results show that the treatment with dapagliflozin did not result in a statistically significant risk reduction in organ dysfunction or death or improvement in clinical recovery. And the serious adverse events were reported in 10.6% treated with dapagliflozin and 33% in patients treated with placebo. And among them, the dapagliflozin group developed 2 cases of DKA, both in type 2 diabetes. So in non-diabetes, the DKA will not develop from this study. So the summary is that in their 19 trial, dapagliflozin did not achieve statistical significance for the dual primary endpoints. But numerically, fewer patients treated with dapagliflozin experienced organ failure or death, and dapagliflozin was well tolerated. So the implication is that the results do not support discontinuation of SGLT2 inhibitors in the setting of COVID-19. The other example of the use of SGLT2 inhibitor for inpatient is the SOLO-AS WHF trial, the sotagliflozin in patients with diabetes and recent worsening heart failure, also published in NEJM this year. The trial enrolled patients with diabetes and heart failure and double-blind randomization in hospital or within 3 days after discharge. Patients received sotagliflozin or matching placebo and follow-up for median 9 months. The primary endpoint including cardiovascular death, hospitalization for heart failure, or urgent heart failure visit. And the major inclusion criteria including admission with signs and symptoms of heart failure, treatment with intravenous diuretics, stabilize of oxygen, transition to oral diuretic, and BNP and type 2 diabetes. The key exclusion criteria including end-stage heart failure, recent ACS, stroke, PCI or CABG, and eGFR less than 30. So this study also includes non-critical illness and relatively stable patients with type 2 diabetes and heart failure. So we can see the planned outcome. The result of the primary endpoint was lower in the sotagliflozin group than in the placebo group. It showed that the initiation of SGLT2 inhibitor before or short after discharge in patients who were hospitalized for worsening heart failure were beneficial. An early initiation of therapy represents an important opportunity to improve outcome. as indicated by the high rate of primary endpoint events in the placebo group. So let's see the safety outcome. And we can see that the hypotension, diarrhea, and hypoglycemia were more common with the sotagliflozin than with placebo. And the percentage with acute kidney injury was similar. The severe hypoglycemia was more common with sotagliflozin than with placebo. So that's the second example of SGLT2 inhibitor use for inpatient. So the summary of my talk is that GLP-1 receptor agonists and SGLT2 inhibitors have clear cardiorenal benefits and were increasing use in diabetic care. Patients use this medication will become increasingly seen in acute setting, and hospitalization represent an opportunity to initiate these benefit result drugs. A pilot study showed that the advantage of GLP-1 receptor agonist with normalization of glucose, lower glucose variability, and lower risk of hypoglycemia. The DARE19 trial and soloist WHF trial showed acceptable safety for SGLT2 inhibitor in inpatient. However, trials regarding the short-term risk and benefit are needed to establish the role of GLP-1 receptor agonist and SGLT2 inhibitor in acute illness patients. Thank you.